Awesome. Hi, everyone. Thank you for joining us for today's Sepsis Workgroup presentation. My name is Emily Bear, and I am a Site Engagement Coordinator with MVC, and it is my great pleasure to be facilitating this workgroup for you today. All right. See if my slides will progress here. Good. Today's work group is going to feature a presentation by Christina Ledbetter from McLaren Oakland Hospital. And I'm just going to give you a brief bio on her. She's had a lot of experience. So Christina has been a registered nurse for 15 years. She's a graduate of Chamberlain College of Nursing, where she earned a Bachelor of Science in Nursing in 2020. And she previously obtained her associate degree of science in nursing at St. Clair County Community College in 2009. She has spent the bulk of her nursing career with McLaren Healthcare in various roles, including caring for patients as a staff nurse on various units, as an assistant clinical manager for the PACU and endo units, and clinical manager for the pre-admission testing department, metabolic and bariatric program coordinator, interim joint replacement program coordinator, and quality improvement specialist. She currently serves as a quality improvement specialist RN at McLaren Oakland, and she serves as the SCQR for MSQC and manages the CMS SEP1 bundle compliance program, as well as many other functions, I'm sure, within her department. In her downtime, Christina enjoys visiting estate sales, road trips, long weekends, and drinking coffee on her deck. She is going to be presenting today on McLaren Oakland Hospital's efforts to form a Sepsis Excellence Committee, and I'm sure all who are in attendance today are very excited for this presentation. I know we are. But before I turn it over to Christina, we do have a couple of housekeeping notes I wanted to remind us of. First, as you may have been aware, this workgroup session is being recorded. The slides and the recording will be made available to you following the conclusion of the workgroup. So be on the lookout for an email from us with all of that wonderful information included. Next, we will be holding questions until the conclusion of the presentation, but please feel free if something comes up during Christina's presentation that you don't want to forget. You can add questions to the chat throughout the presentation, and we'll kind of collect those and ask those questions of Christina at the very end of the presentation. Lastly, your feedback is very important to us. At the conclusion of the presentation, we will provide you with a link to the post-work group survey, and we would greatly appreciate you completing that survey. As a reminder, for hospitals participating in P4P, completion of that survey is mandatory to receive credit for participation. Additionally, I would note that attendance to as much of this work group as possible, we prefer close to 80%, is appreciated for credit for participating in this work group today. And with that, I'm going to pass the torch over to Christina for her presentation. We'll stop sharing.
All right, thank you, Emily. Let me see if I can share my screen. There we go. Can everybody see this? Let me see. I have to click share. Okay. Can you see the screen now? Okay, perfect. So thank you, Emily, for the wonderful introduction. My name is Christina Ledbetter. I am an RN Quality Improvement Specialist at McLaren Oakland. And I was invited today to speak about our Sepsis Excellence Committee and a little bit about what we've done to improve our compliance numbers over the last probably 18 months or so. We've been working on this for a very long time. So financial disclosures they asked me to provide. Obviously, I am an employee of McLaren Oakland. I have no other relevant financial relationships to disclose. A little bit of history about McLaren Oakland, just so you can kind of see the size of our hospital. We are a 318-bed hospital. We are a verified level 2 trauma center. We are a primary stroke center. We offer several different service lines. We serve the Pontiac and Oakland County community areas. We have several different medical communities that are off-site, such as in Clarkston and Oxford. They have freestanding ED centers. And then we also are a teaching hospital. We do have residency and fellowship programs, which the residency program is very helpful to our sepsis program because many of the residents will use sepsis as some of their QI projects that they're required to take part in. So we've had a lot of good support from our residents. So just to kind of look, to give you an idea of where we were before we kind of really started everything. We were observing poor compliance prior to March of 2023. So over a year ago, our audits were revealing that our providers were following the CMS bundle criteria, but they just were not documenting the good work that they were doing in the correct sequence. As we know with CMS sepsis, the timing is very, very critical. And so they were doing everything, they were documenting in real time after the fact, after they were doing all of their good work. And they weren't documenting such as like the antibiotic was given after the blood culture. So we created some worksheets and such to kind of go over that. We also did some enhanced resident and attending education just on documentation and like how to chart it, where to chart it, and what's really important for us. The bottom graph is just an overview of our compliance. I included 2022 because you can see there our numbers were in red. So our compliance was a little bit lower. We really started making the good pushes. As you can see, we went from 36% compliance to 82% compliance February to March. That was when we had created our flow sheet, which I'm going to share with you shortly. And then we developed our Sepsis Excellence Committee. We actually brought that together last year towards the end of the year, and we'll kind of go over some of what we do in our committee. So for our Sepsis Excellence Committee, one of the important things I do is I share the data monthly. I share it with the ED operations meeting and also the critical care committee. And then we also discuss the data at the Sepsis Excellence Committee. In the committee, in the very beginning, we were kind of going through each case, drilling down on the, like, why did the case fall out? And that's how we identified it was more of a charting issue versus, you know, an actual care issue. So that's where we kind of honed in that we needed to really drill down on that education and get the education out there. The SEC is a multidisciplinary team. We do have an executive leadership. Our CMO is our sponsor. We have pharmacy, lab, nursing unit leaders. A CNO comes. Sometimes attendings will come, residents, nursing staff. We've had come before, infection prevention. Obviously, quality, we're there because we're driving the committee. But we wanted to make it all-encompassing so that we could have representatives from each unit that directly impacts our sepsis compliance numbers. Work that we've done, we started to develop some A3 projects after we identified our top areas of fallout. So we chose 2 of the top areas. We did get the enhanced education to our leaders and providers. And again, we do still discuss fallout reasons if it's a truly a fallout and not if it's a care fallout where maybe we didn't give the antibiotic within the 3-hour time frame. That's something that we will still discuss. But if it's a fallout due to documentation, we just kind of let the provider know what they should have documented better. We don't really discuss the treatment part. We do notification to providers on all fallout cases, and I'm going to share the letter that we send out to each provider just to give you kind of an idea of what we have. I think I may have shared similar through this group before, but this is a notification letter that is standard that we would typically send out. This letter is sent to the attending of record, the resident, and this is at the time that sepsis is diagnosed. So if it's diagnosed in the ED, this goes to the ED attending and resident, or it will go, if they're inpatient, it'll go to whatever inpatient unit they were on when it was diagnosed. This one here, I did black out some of the sensitive information, but this is a very good example of the letters that we send out. We have the demographic information for the physician to go in and review their chart, so they can kind of see. I will usually put a little case summary. I try not to get too lengthy there just because, you know, they're going to be reading in the chart anyway, but just maybe some medical history there, the past medical history. What I'd really like to include is on the top right, the sepsis criteria. So this is what, as an abstractor, this is what I'm looking for when I'm going in and I'm abstracting to see, does the case even meet CMS severe sepsis criteria? So I can kind of quickly point these out to the provider. This is, you know, what I found, and these are the positive indicators are highlighted yellow. I'll give an overview of the non-compliance. If it is attributed to a nursing staff error, such as this one, I still will notify the attending resident leadership and the unit leadership because I want them to be aware of their case status. And it helps, we've learned that it helps to kind of, it helps the providers to remind nurses, you know, to document in the proper time frame, or, you know, ask, did you draw that lactic acid? Or, you know, it kind of increases that communication because they'll remember, oh yeah, my case fell out because this was documented in error. So if it is a nursing error, it is also sent to the nursing leadership to discuss with their staff. I don't send this type of letter to the staff nursing. However, you probably could if you wanted to, you know, for improvement opportunities. We do list those here, and that could be beneficial for a nurse as well. So something that, you know, we may even consider here in the future at Oakland if we continue to have increased nurse staff fallout. So one of the things that we did that really, really increased our compliance, and this was back between February and March, where you saw the graph that I showed that we went from red numbers to green numbers. This is the worksheet that we created. I think it's been tweaked several times, and I think there may be even one newer rendition because we had added a couple of things. But when we initiated this worksheet, it is mandatory for all sepsis patients. Any patient that is identified with sepsis, the physician is to put a patient label up in the left-hand corner. They're going to put time 0, which is the time that the sepsis was recognized. And then they're going to give this flow sheet to the nurse. So this is going to help guide the nurse as to far as all of the items that need to be completed within 3 hours, and then any items that need to be completed within the 6 hours. There's additional information. We kind of left that on there just to help guide the nurse or the provider if they need to determine between sepsis, severe sepsis, or septic shock. But the treatment pathway is the same for all three categories. We're going to be getting the initial lactic acid, the blood cultures. We want to make sure we're getting that antibiotic started in time because that's how we treat sepsis. So this flow sheet is used for any patient that has signs or symptoms of sepsis and a known or suspected infection. These are a great tool. Some things that we've noticed, sometimes the times on the worksheet, the nurse may have documented on the worksheet that they collected the lactic acid at noon, but in the EMR, they entered it at 1 o'clock. So what we've done with our education is kind of taught, if you're not charting in real time, and you're sitting down to do your charting maybe an hour later or whenever you have time, use this sheet as a guide to date and time exactly when you're doing those action items, when you're collecting the lactic acid or when you're collecting the blood culture, and definitely when you're hanging the antibiotics. If you're not hanging it right at the time you're documenting, you want to make sure you put the time that you actually hung it. So we really worked hard on that. We did kind of go back and forth just because some people thought this documentation, or this was like official medical record documentation. It is not considered official medical record. The source of truth has to be documented in the EMR. So we included that with our education, and it's gotten much better where any information that's documented on the worksheet is also being documented into the EMR. Sometimes the doctor, the nurse, or any provider, they might write some scratch notes off to the side in one of the blank areas and say, you know, possible pneumonia or something like that. It kind of lets me know what they're thinking, but it really has no bearing on the case because this is not an official source of documentation. So they would have to make sure that they put that in their ED note. These sheets are supposed to be collected in the emergency room, and they're held in a binder for about 1 week, and then they're sent to medical records for them to scan. And obviously, we know anytime we're working with paper documentation that has to be scanned, sometimes they go missing or they just don't get scanned into the EMR. So that is something that we have also noticed, some drawbacks that we noticed with our flow sheets. But the flow sheets have definitely increased our compliance. It's really made the documentation a lot better, and then it's guiding the providers and what they need to do and what time frame and what needs to be done first. The other thing we did, we created a dot phrase or an automatic text note. I know different people call it different things, but this is the dot phrase that we use here at Oakland. There were many, many different dot phrases that were being used. Some were outdated, some were just not really have the correct information. And so this is one that we recently had worked on. So at McLaren Oakland in the ED specifically, this dot phrase is mandated. The provider must use this specific dot phrase. And we have noticed with making that the requirement that we've also helped to increase our compliance even further. So we do have to have them, we do monitor if they're using a dot phrase, which dot phrase are they? You know, we try to discern which one that they're using and make sure that they have all of that correct information. When we did our education with the residents and the attendings as far as documentation, I went through and did like a breakdown of each of the different areas. The top third area is basically our sepsis recognition. The second third is our severe sepsis recognition. And it also gives some tips on what the action item is, like give your antibiotics, make sure you're drawing your lactic acid. If it's over 2, it needs to be repeated. The last area, it's more the septic shock. So if your patient is meeting the septic shock criteria, and then we also include our reperfusion exam. So in case the patient has to have a fluid bolus and they are going to need a reperfusion exam, our provider just has to enter this dot phrase and make sure that they're time stamping it. And this really helps to drive the compliance and helps standardize the flow and how we're doing it here at Oakland. Just some things that we did that I wanted to share when we were doing the education and charting tips. I really feel like that was very, very beneficial. A couple of years ago, I want to say I did a resident education, and we kind of like, it was more of a broad overview of sepsis and like the CMS bundle, which I really think that the providers, they understand, you know, the treatment of sepsis and so forth. And when we created our committee and we realized that, you know, it's not a knowledge deficit as far as like what the CMS bundle is, it really was a knowledge deficit of how to document all that good work that they're doing. So these were some of the education tips that I gave when I did the education recently. I try to impress upon the providers that if they are the diagnosing or if they're documenting a sepsis presentation, then they are now the responsible person. They have to take ownership of that case and make sure all of the labs are drawn, the fluids are given, antibiotics, and all the measures are completed. So if that case were to fall out, that's who I would be attributing the case to, is to whoever diagnosed it first. I also impress upon all of our providers the timestamp. And I always tell them, if there's absolutely nothing you remember from me giving the presentation today, please remember to timestamp, because the sepsis criteria is very, very time sensitive. And so I know, I'm not sure if everyone on the call is an abstractor for CMS, but you know that those timestamps are very, very important, and everything is critically timed. So if there's no timestamp, we have to use different times, like maybe the time the note was opened or the time the patient was seen or things of that nature, which can distort your entire timeline. So if you aren't using timestamps at your healthcare facility, I mean, that would be my #1 recommendation. I also ask the providers to be very specific in their charting, because we aren't able to make inferences. So if we have a patient that maybe was hypotensive after taking a pain medication, we want to make sure that that's clearly spelled out in the narrative charting. Then we can disclude the hypotensive reading if it's something that's normal for the patient, or if it's something due to a medication. So I try to impress upon the providers to make sure that they're making those, linking things together, because sometimes we do have an elevated creatinine or something, and maybe the patient was dehydrated and it really wasn't due to an infectious source. So we always encourage the providers to document if an abnormal lab value or an abnormal finding is related to something that is not related to infectious source, or is related to a normal condition for that patient. I think we kind of already talked about the organ failure measure. Again, the creatinine, if it's elevated. The other thing I also try, one of our biggest issues that we had identified was the IV fluid bolus, the calculation, and how it was documented and being given. So we really pushed hard on our education for the IV fluid bolus. And I just tell my providers, if we're going to deviate anything from the bundle, there has to be a specific reason why. And this could work for blood culture. If the nurse attempted the blood culture and they couldn't draw it, but the antibiotic's ready and the patient's just deteriorating and they can't wait till the blood culture is drawn, we want to make sure we're giving that antibiotic. As long as that's documented, that can be an acceptable reason of why that was done. So I always encourage the providers that if we're doing anything, if we're deviating anywhere from the bundle requirements, that they just document why we are deviating from that. And the biggest one for us, again, was the IV fluid bolus. So we did find out that a 0 IV fluid bolus is not a target volume. So we kind of went back and forth with CMS trying to figure that out. But if the physician truly feels that the patient should get no IV fluid at all, it has to be documented, either patient refusal or the patient advocate refusal. So those were some of the charting tips that we went over. And I think that's all I had for you today. That's kind of the work that we've been doing through our SEC committee. We do meet monthly with our committee, and like I said, we still, we'll go through cases, but we're more, instead of going through each case to talk about why it fell out, we kind of are talking about what can we do to prevent these fallouts from continuously happening, and trying to make some quality improvements with the process and the documentation so that we can continue to be in compliance. But that's all I have.
Emily, we can't hear you very well, I don't think, unless it's just me.
I'm not hearing, but
Okay, can you hear me now?
that's better. Yes.
Okay, I don't know why my microphone flip-flops, but it seems to. Thank you, Christina, once again for that presentation. I think it was very informative, and we've already gotten a couple of questions in the chat. Most of them sort of surrounding the EMR and wondering, first there was a clarifying question from Paula. She was wondering the ED worksheet, is it entered into the EMR? And then Amy asked, why is the worksheet sepsis checklist not part of the medical record? If it's included in the episode of care medical record and it's dated and timed for the different elements. So I think those kind of go together, just a clarifying if it is entered into the EMR. And then to Amy's point, why is it not part of the medical record? If you would mind speaking, Christina.
Yeah, sure. So the worksheets are scanned into the EMR. The problem that we were finding was a lot of inconsistencies where, let me see if I can bring we don't consider it to be part of the medical record because sometimes the documentation on the worksheet was not matching what was in the EMR. So we as a site have said that whatever is actually charted in the EMR is going to be the source of truth. So if the nurse is documenting on the worksheet that they drew the lactic acid, like I said, at 1 p.m., but they're not documenting it in the EMR, it says 2 p.m., we take the 2 p.m. time because that is what's in the electronic medical record. And that's why we impressed upon the staff to use the worksheets as a guide when they finally are sitting down to chart. That was one of the things that we had learned when we were kind of looking at the process of everything is the nurses particularly were not charting. If they were doing the blood culture and the antibiotic, they would just scan them and that's the time it would timestamp it. And sometimes it would be out of order. The antibiotic would appear to be given before the blood culture, but it's just the way that the nurse scanned it. So we tried to impress upon them to just use that worksheet as a guide for when you are sitting down charting. We do scan it into the record just for comparison. It's like I said, we don't use it as official. I don't know the different rules that the different sites. If that would be possible to use it as your official medical record, but here we do not. We only use the electronic medical record. The EMR, we use Cerner, so we don't have Epic or anything fun like that.
Thank you, Christina. I appreciate that. All right. There was another, I'm not sure, Amy, if this was a question or a comment. Amy noted zero fluid only allowed with physician or nursing documentation that patient is not volume responsive based on CO, CI, SV, or SVI. Amy, would you mind letting us know if that was just a comment or if there was a question there? I think she is muted.
Can you hear me?
Yeah, we can hear you.
Hi, thanks. This is Amy. Yeah, I was just making a comment that zero fluid is not allowed. The only way you can do zero fluid is if the patient refuses, which I've never had a case that I found that. And then the other reason is if you have physician or nursing documentation that the patient's not fluid responsive, and you have to base that on one of those methods, the cardiac output, the index stroke volume, or so forth.
Okay. Thank you for that information, Amy. All right, our next question is from Tammy. How did the RNs and providers react when they were told the worksheet and dot phrase were required? And did you have a lot of pushback?
we did have some pushback, but honestly, the chief of the emergency department and the supervisor for the emergency department and myself, we are the ones that created the worksheet, so they were fully on board. The leadership team, I don't know how the staff really felt about it. I know it took a little bit to gain traction, but our chief of the emergency room is very, very engaged with sepsis, and he is very, he's a strong component as far as giving out the education and saying, this is what we're using now. So we really didn't get a whole lot of pushback. We did get some, you know, because people just thought it's an extra piece of paper. But I mean, right away we saw the benefits of our compliance went from 39% to 82% from 1 month to the next when we implemented the worksheet. So there was no discrepancy that the worksheet was helping, and so I think everybody saw that and they bought in. We don't have very much, I mean, everybody pretty much uses the worksheet now. Like I said, it's just kind of hit or miss if it's scanned into the record because it is a worksheet and so it has to be scanned in. But we really do have, our chief of the ED is very supportive. We do kind of have an unofficial sepsis champion that works in the ED as well. So they really help to facilitate that buy-in in the emergency room department. Our next focus through the Excellence Committee is we're gonna start focusing on the inpatient side because we really hardwired the process in the emergency room. So we're trying to tailor the worksheet and the dot phrases and everything like that to work with the inpatient side so that we can increase our inpatient compliance as well.
Thank you for that wonderful question from Tammy. Tammy, I have to call you out. You have an awesome background on your video. I don't know if anybody can see that. Spot sepsis, great. Sorry, I think you were eating. All right. Let's see.
Oh, sorry, that's the other Tammy. Actually, there's two Tammy
Oh,
G's. And
There are two Tammy G's on there. I got you.
That's Tammy Gallagher. She's from My Help West.
Tammy
But thank you.
Garcia,
I
your
appreciate you.
background.
Thank you.
I just saw Tammy G up there. All right. So let's see. Our next question is from Carly. You mentioned the sepsis dot phrase is mandatory for providers to use. Can you speak to how you got buy-in for this, as well as how you educated on it? The current culture in our ED creates a struggle for provider accountability, even with expected work. Any tips would be appreciated. I think you've spoken to this quite a bit already, Christina, but if you have any other tidbits to add?
I mean, the only other thing I would add is we do monitor now that the specific dot phrase has been mandated. And I want to say that just started more recently, earlier this year. So it's something newer for us. But I do monitor that when I'm doing my chart audits, and then I notify Dr. Wall, who is our chief of the ED, and he will take it and speak to the residents and attendings and, you know, let them know, like, why are you not using this dot phrase, especially if it caused the case to, you know, be non-compliant or something of that nature. We really haven't had, most of the providers were using some type of dot phrase. So we just kind of cleaned it up where they're now using the specific one. I think Dr. Wall, like I said, he's very fantastic. And I think because he is such a champion of the sepsis that he works with his staff in the ED, and they really listen to what he has to say. So I understand, like, the buy-in part, it sometimes is very difficult to get the providers to buy in on it. But our ED functions, they seem to function very well where they have the different, they're willing to try new things or say, okay, this is the process now. So we are very fortunate in that area.
Thank you for that. All right, next question was from Joy. Have you worked on the positive qualifying list? Rule out it in a lot of our charts. And then she mentioned indications. If you need clarity on that question, maybe Joy could speak up.
Certainly. Thanks so much. I've been meeting with our residents and our ED providers, and ultimately from CMS, from their slide deck and some of their Q&A formats, our providers are using terminology that counts as a positive presumption for an infectious source. And so rule out is one of those phrases. And unfortunately, it's in our indication for chest x-ray. I mean, I found it all over the place. So I was just trying to see if anybody else had scenarios. It's really tricky to get people to change their terminology. They're very comfortable in what they're using. And so the less likely or less indicated, some of those phrases, I'm not sure if anybody else or if Christina, you have been working on that specifically with your providers, because that seems to ding us, unfortunately, more than I would like.
I would say I have not seen that here at Oakland as far as like the rule out indications. Our dot phrase really helps to clear a lot of that up, but I know what you're saying about like the chest x-rays rule out pneumonia and so forth. So I'm not quite sure. I don't know if anyone else has any input on that, if they have that at their site.
Hi, this is Amy. I can't really speak to about telling the physician. Well, I guess I can. Well, anyway, I'm an abstractor and I do have maybe I can send it to the group somehow. I have a list in my notes. I have a list of many positive qualifiers and many of the negative qualifiers. So for sepsis, severe sepsis, septic shock, maybe I can send that to the group and then you can.
Amy, if it's something that you can send a link to, feel free to send it in the chat. But if it's more of like
it's
a
my
PDF,
Word document notes.
Yeah. Do you mind emailing it to me and then I can send it out to the group?
Okay, hold on one second.
I'll put my email in the chat.
Okay, great. Thank you.
Mhm. All right. Let's see, scrolling down. Paula had a question. Does your site use sepsis order sets? And if so, how many do you have and how compliant are your providers in using them?
Yes, so we do have order sets, and that is also something that we just started monitoring probably about the same time that we started monitoring the use of the dot phrase. We have 3 different order sets. One of them is the most commonly widely used. It's the ED, fever, sepsis, weakness power plan or order set. And that's what is mainly used in the emergency room. Sometimes I will see the provider may have used a different order set or power plan just because the patient may have presented a little bit differently, like with chest pain or something like that. So they're following that order set. But they're still getting the sepsis orders in, they're just using a different order set. So we do have very, very good compliance through our ED using the fever, sepsis, weakness power plan. And then for our inpatient sides, we do have like a 2 order sets, a sepsis admission order, and I think it's called a sepsis focus order. I'm not quite positive on the terminology, but we have much less compliance on the inpatient side. So that is something that we will, as we work through our committee, we'll be trying to get that more educated to the residents and attendings on the inpatient side, that those are available for them, as well as how to chart and those types of things. So we do have those and we do monitor those. I look at them when I'm abstracting the case, and then I also have a report that I can get monthly as to how many times the order sets were used.
Thank you. All right, and then I have a question and a comment from Carly. Question was, how many attendings do you have? And then comment was that we changed our indicators for chest x-ray to risk 4 instead of suspect or rule out. I'm wondering, Carly, if you want to speak to that at all.
Oh, sure. We noticed that we are having like our infection time was based off of, you know, our chest x-rays being ordered out in triage, which could be many hours prior to a physician being able to actually evaluate the patient. So we updated our indicator to be risk for sepsis, just to have a more appropriate like infection time based on when the providers are actually able to evaluate the patient or that x-ray comes back.
And then Christina, Carly's question was how many attendings do you have? I'm not sure if that's information that you would be willing to share.
I honestly don't know the answer to that, so I really couldn't say. As I was kind of looking at your comment question, I was like, gosh, like trying to think how many do we have, but so I guess there's probably 10 to 12 maybe. We are a smaller site, so it just kind of depends, but there are obviously the main people you see all the time that come across in the charts. So I'm not quite sure the exact number.
Thank you for that. All right, that is all of the questions that I had in the chat. Does anybody else have any additional questions you'd like to speak up about or comments? I mean, anybody trying similar things at their site that they'd like to speak about or ask the group questions about? Well, if not, I'm just going to finish us up with a couple additional housekeeping things. I'm going to share my screen again. All right, hopefully everybody can see my screen now. So just letting you know that we've got one last sepsis work group in the sepsis series, and that's going to be on October 17th, as always at noon. Additionally, we have a couple other upcoming work groups in our other work group series. The preoperative testing work group will meet again on August 5th. That'll have a presentation by Jenny Kinder from Ascension St. Mary's Hospital. And then the cardiac rehabilitation work group will meet on August 22nd. That will be a presentation by Sarah Bigelow and Kelly Kinney from Corwell Health Farmington Hills. All right. And a reminder again, all of our work groups are at 12 o'clock. And to achieve the 0.25 P for P engagement points for attendance to our work groups, your site will need to have attended and completed surveys for all 4 of the work groups for each of those series, with the goal of participating in at least 80% of each of those sessions. All right. And with that, we will conclude our work group session for today. Thank you so much for attending. Please be sure to submit your survey. Hopefully one of my team members will be dropping that in the chat here briefly if they haven't already. That link will also be in the follow-up email that should come out in the next couple of hours. We just got to get the link together for everything. And I think Lisa sent me some stuff, so I will add all of those references to the email for you as well. And then as a very last reminder, please on the survey only select the hospital that you are attending on behalf of for attendance credit for that site. All right, thank you and have a good rest of your day.